In this video, I will talk about spinal muscular atrophy. Spinal muscular atrophy, or SMA, is an inherited genetic disorder that affects the motor neurons in the spinal cord and motor nuclei in the lower brainstem, leading to progressive muscle weakness and atrophy. It is primarily caused by mutations in the SMN1 gene, or survival motor neuron 1 gene, which is responsible for producing a protein called survival motor neuron, or SMN protein. This protein is essential for the survival and function of motor neurons. SMA is an autosomal recessive disorder caused by mutations or deletions in the SMN1 gene, which is located on chromosome 5q13.1. Chromosome 5 is one of the 23 pairs of chromosomes found in the human genome. It's a crucial component of the genetic blueprint, containing thousands of genes that play vital roles in various bodily functions and traits. Chromosomes are located in the cell nucleus, and they are thread-like structures composed of DNA and proteins and serve as carriers of genetic information. Each chromosome consists of two arms, referred to as the P arm and the Q arm, which are separated by a region called the centromere. The P arm, derived from French word petite, which means short or small, stands for the short arm of the chromosome, while the Q arm, derived from French word Q, which means tail, stands for the longer arm of the chromosome. So, the location of specific genes and genetic information along the chromosome is often described based on their position relative to the centromere and the P and the Q arms. Additionally, chromosomes are divided into bands, and these bands are further subdivided into smaller regions called cytogenetic bands. These bands are numbered in a standardized way based on their position along the chromosome. Therefore, 5q13.1 denotes a particular region on the long arm of the chromosome 5, which is the segment between bands q13 and q14. The one after the decimal point further refines the location within the band and represents a subband within the main band. On chromosome 5q13, there are two crucial genes responsible for producing the survival motor neuron protein. The primary and the most important gene is SMN1, while the other significant gene is SMN2. SMN1 and SMN2 are closely related genes located on chromosome 5q13, responsible for producing the survival motor neuron protein, critical for motor neuron function in the spinal cord. The SMN1 gene generates the full-length functional SMN protein, while the SMN2 gene produces a slightly different, less stable version of SMN protein due to a signal nucleotide difference. A mutation in the SMN1 gene that leads to a deficiency or absence of functional SMN protein lead to spinal muscular atrophy, or SMA. SMA severity depends on the number of functional SMN copies produced by SMN2 gene, which can partly compensate for the loss of SMN1 function. The SMN1 gene provides instructions for producing the survival motor neuron protein, which is essential for the normal function of motor neurons. These motor neurons are located in the spinal cord and transmit signals from the brain to the muscles throughout the body. The SMN1 gene consists of 9 exons that encode the SMN protein. Please remember that exons are segments of a gene that contain the necessary genetic information to produce a protein, and they are connected together through RNA splicing to generate the final mRNA transcript that will be translated into a functional protein. Also, introns are non-coding regions between exons, and during gene expression, introns are removed and exons are joined to form functional mRNA for protein synthesis. Mutations in SMN1, especially the deletion of exon 7, are the most common cause of SMA. Individuals with SMA have a mutation in the SMN1 gene that leads to a deficiency or absence of functional SMN protein. In the case of SMA, there is a deletion of exon 7 in one or both copies of the SMN1 gene. This deletion can occur during DNA replication or recombination process, result with loss of genetic material. For understanding this process better, let's recall the basic knowledge about gene expression process. Gene expression is the fundamental process by which genetic information encoded in DNA is utilized to produce functional proteins in cells. The process of turning the information encoded in the SMN gene into functional protein involves several steps, including gene expression, transcription, splicing, and translation. Transcription. The process begins with gene expression. The DNA sequence of the SMN gene serves as a template for the creation of a complementary RNA molecule, known as messenger RNA or mRNA. The SMN gene contains 9 exons, which are coding regions. You can see 1, 2A, 2B, 3, 4, 5, 6, 7, and 8, a total 9 exons. interspersed with introns. Exons 6, 7, and 8 are the specific segments of the gene that contain important genetic information for producing the survival motor neuron protein. During transcription, the DNA sequence of the SMN gene is read by an enzyme called RNA polymerase. This enzyme creates a corresponding mRNA strand by copying the genetic information from the exons. Transcription process followed by splicing. Once the mRNA strand is created, it includes both exons and introns. However, before the mRNA can be used to synthesize a protein, the introns must be removed and the exons need to be joined together. This process is called splicing. Splicing is carried out by a complex of molecules known as spliceome. It recognizes specific sequences at the boundaries between exons and introns, allowing it to precisely cut out the introns and connect the exons together. Exons 6, 7, and 8, along with any other exons present in the SMN gene, are spliced together in a specific order to form a mature mRNA molecule that represents the complete coding sequence for the survival motor neuron protein. Final process is translation. The mature mRNA, now containing the correct sequence of exons, leaves the cell nucleus and enters the cytoplasm where protein synthesis takes place. Ribosomes, the cellular machinery responsible for protein synthesis, read the mRNA sequence in sets of 3 nucleotides, which are also known as codons. Each codon corresponds to a specific amino acid. Transfer RNA, also known as tRNA molecules, brings the appropriate amino acids to ribosome in a sequence determined by the mRNA codons. The ribosome catalyzes the formation of chemical bonds between amino acids, ultimately creating a chain of amino acids known as a polypeptide chain. The polypeptide chain folds into its functional protein shape. In case of SMN gene, this protein is survival motor neuron protein, which plays a crucial role in motor neuron health and function. Any disruptions or mutations in this process can lead to disorders like spinal muscular atrophy due to impairment of protein function. The deletion of exon 7 disrupts the normal process of gene expression, so one of the problems it causes is altered RNA splicing. The deletion of exon 7 disrupts the normal splicing of RNA molecules transcribed from the mutated SMN1 gene. RNA splicing is a process which non-coding regions, which are introns, are removed, and the remaining coding regions, exons, are joined together to form a mature messenger RNA, which is mRNA molecule, as I mentioned previously. Production of a truncated protein. Without exon 7, the splicing machinery produces an altered mRNA transcript from the mutated SMN1 gene. This transcript lacks the critical sequences encoded by exon 7, resulting in the production of a truncated SMN protein. This truncated protein is usually unstable and rapidly degraded, leading to a severe deficiency of functional SMN protein in affected individuals. Loss of exon 7 results in the production of an unstable truncated SMN protein or no functional protein at all. The severity of SMA depends on the amount of the functional SMN protein present. The deficiency of functional SMN protein leads to motor neuron degeneration, muscle weakness, and SMA symptoms. Without enough SMN protein, the motor neurons gradually degenerate and die, leading to muscle weakness and atrophy. The SMN2 gene is nearly identical copy of SMN1, also located on chromosome 5q13, which means they are found on the long arm, which is the Q arm of chromosome 5 at the position 13. These genes are physically close to each other, and they are arranged in tandem on the chromosome, meaning they are adjacent to each other on chromosome 5q13. SMN2 produces the SMN protein as well, but there is a critical difference between the two genes as I mentioned before. A single nucleotide difference in SMN2, known as C to T transition or cytosine to thymine transition, leads to inefficient splicing and exclusion of exon 7 in most of the transcripts. Consequently, the majority of SMN protein produced by SMN2 is truncated and less stable compared to the full-length SMN protein produced by SMN1. SMN2 copy number and SMA severity. The SMN2 gene is present in multiple copies in the human genome, varying from 0 to 8 copies per individual. So the number of copies varies among individuals. The less copies of SMN2 a person has, the less potential there is for producing functional SMN protein. However, due to the instability of SMN2-derived protein, the actual amount of functional protein produced is limited. The severity of SMA is inversely correlated with the number of SMN2 copies. Individuals with SMA typically have mutations in both copies of SMN1 gene and a varying number of SMN2 copies. Those with fewer SMN2 copies tend to have more severe forms of the disease, while those with more copies may have milder symptoms. It is worth noting that while SMN1 is the primary gene associated with SMA, SMN2 also plays a role in the disease severity due to its ability to produce a small amount of functional SMN protein, albeit at the lower levels compared to SMN1. Now let's talk about clinical features of SMA. SMA were traditionally categorized as types 1 to 3, but are recently classified as type 0 through 4 based on the age of onset and clinical course. SMA type 0, also known as prenatal onset, and SMA type 1, also known as infantile onset, are the most common and severe forms, while SMA type 2 and type 3 have a later onset and a milder course. SMA type 4, adult onset, is the least severe. While these subtypes are useful for prognosis and treatment considerations, it is evident that SMA severity exists on a spectrum without clear-cut boundaries. In all forms of SMA, patients experience symmetric muscle weakness predominantly in the proximal muscles of the lower limbs. Deep tendon reflexes are either absent or significantly reduced. Additionally, SMA is associated with progressive respiratory insufficiency, particularly in type 0 and 1. Sleep disturbances can occur occasionally in children with SMA, and SMA type 0 may be accompanied by congenital heart defects. SMA type 0 is the most severe and rarest form of SMA, and it is characterized by prenatal onset. This means the symptoms of the condition become apparent during pregnancy or shortly after birth. Here are the clinical features of SMA type 0. Severe muscle weakness. Infants with SMA type 0 experience profound muscle weakness throughout their bodies. This weakness affects both the upper and lower limbs. Hypothenia. Hypothenia refers to reduced muscle tone and is a prominent feature of SMA type 0. Infants with this condition have floppy and weak muscles. Areflexia. Areflexia means the absence of reflexes. In SMA type 0, affected infants typically do not exhibit deep tendon reflexes. Facial dysplasia. Facial dysplasia involves weakness or paralysis of muscles on both sides of the face. Congenital heart defects. Some infants with SMA type 0 may have congenital heart defects, which are abnormalities in the structure of the heart present at birth. Arthrogryphosis. Arthro means joint, so arthrogryphosis refers to multiple joint contractures, where the joints have limited range of motion and are fixed in abnormal positions. It is often present in SMA type 0. Absence of motor milestones. Due to severe muscle weakness, infants with SMA type 0 are unable to achieve typical motor milestones such as rolling, sitting, or standing. Respiratory issues. Respiratory problems are a significant concern in SMA type 0. The weakened muscles involved in breathing lead to respiratory insufficiency, which can be life-threatening. Infants diagnosed with neonatal onset SMA may display indicators of fatal hypokinesia deformation sequence, such as excessive amniotic fluid, which is also known as polyhydramnios, delayed growth in the womb, which is also known as intrauterine growth retardation, and underdeveloped lungs, also known as pulmonary hypoplasia. This type of SMA is often fatal within the first few months of life. Unfortunately, respiratory failure typically leads to death by the age of 1 month to 6 months. Typically, infants with SMA type 0 have a single copy of SMN2. That is why infants with SMA type 0 have a short life expectancy due to the severity of the condition. That occurs within the first few months of life, typically by 6 months and often as early as 1 month. Prevalence varies, so we can say approximately between 1 in 10,000 to 1 in 25,000 live births. SMA type 1, also known as Infantile Spinal Muscular Atrophy or Werdnig-Hoffmann disease, is a severe form of SMA that typically becomes evident within the first 6 months of life. Initially, affected infants may seem normal, but soon they develop severe and symmetric flaccid paralysis, impacting both their upper and lower extremities, rendering them unable to sit unsupported. Motor milestones are significantly delayed in SMA type 1 due to progressive degeneration of motor neurons. The lack of functional motor neurons hinders the development of motor skills, making it challenging for affected infants to achieve essential milestones such as lifting their head, rolling over, sitting, standing, or crawling at the expected age. Despite these motor challenges, the upper cranial nerves are mostly spared, leading to an alert expression, furrowed brow, and normal eye movements. However, weakness in the bulbar muscles causes a weak cry, poor suck and swallow reflexes, pooling of secretions, tongue fasciculations, and an increased risk of aspiration and failure to thrive. As the disease advances, respiratory muscle weakness results in a progressive decline in breathing function. Symptoms in SMA type 1 progress rapidly, and the majority of affected infants do not survive beyond the age of 2 due to respiratory failure. However, there have been reports of some long-term survivors, possibly attributed to advancement in the management of chronic respiratory insufficiency and more aggressive medical care. Prevalence changes, so approximately 1 in 6,000 to 1 in 10,000 live births. SMA type 2, also known as Dubowitz disease, represent an intermediate form of SMA that typically becomes apparent in early childhood, usually between 3 and 15 months of age. It constitutes around 20% of all SMA cases and is milder compared to SMA type 1. Children diagnosed with SMA type 2 can sit without support, but they encounter challenges in standing up or walking independently. The muscle weakness primarily affects the proximal muscles, with the legs being more affected than the arms, while the face and eye muscles remain spared. Common features include tongue atrophy with fasciculations, areflexia, which is also known as absence of reflexes, and tremor-like myoclonus affecting distal limbs referred to as mini polymyoclonus, dysphagia, known as difficulty in swallowing, and respiratory insufficiency. Many individuals with SMA type 2 may require assistive devices such as braces, wheelchairs, or other mobility aids to aid in movement. The intercostal muscles responsible for chest movements during breathing are particularly affected, leading to paradoxical breathing, where the rib cage moves inward during inspiration while the abdomen moves outward, giving rise to a characteristic bell-shaped chest deformity. Additionally, severe weakness in the legs often causes infants to adopt a frog leg posture when lying down. Despite these features, SMA type 1 does not appear to affect the cardiac muscle, and there is no association with dilated cardiomyopathy. Progressive scoliosis, a curvature of the spine, is common in the SMA type 2, and respiratory muscle weakness can lead to restrictive lung disease. Some individuals may also develop joint contractures and ankylosis of mandible, which can impact mobility and speech. The ability to sit independently is typically lost during the teenage years. Life expectancy varies, with approximately two-thirds of individuals SMA type 2 reported to be alive at the age 25 years, reflecting the variability in the disease course. Patients with SMA type 2 usually have 3 copies of SMN2 gene. Prevalence varies, so we can say approximately 1 in 5,000 to 1 in 11,000 live births. SMA type 3. Spinal Muscular Atrophy type 3, also known as Kugelberg Walender disease or Juvenile SMA, represents a milder form of the SMA spectrum. This type of SMA typically manifests in late childhood or adolescence, with symptoms becoming evident between the ages of 18 months and adulthood. SMA type 3 accounts for approximately 30% of all SMA cases. Individuals with SMA type 3 experience proximal muscle weakness, which primarily affects the legs more than the arms. Despite this weakness, they can achieve independent ambulation, which means being able to walk without support. However, over time, this disease may progress, leading to increasing muscle weakness and challenges with mobility. Some individuals may eventually require mobility aids, such as braces or walkers, to assist with the movement as the condition advances. The presenting symptoms of SMA type 3 often include falls and difficulties climbing stairs due to weakness in the legs. While ambulatory patients may develop foot deformities, they typically do not experience severe scoliosis or debilitating respiratory muscle weakness. Unlike SMA type 1 and type 2, SMA type 3 is associated with a normal lifespan, and affected individuals can live into adulthood with appropriate medical care and support. Patients with SMA type 3 generally have 3 or 4 copies of SMN2 gene, which partially compensates for the deficiency of the SMN1 gene. The additional copies of SMN2 allow for high levels of functional survival motor neuron protein, contributing to the milder course of the disease. Prevalence: SMA type 3 affects approximately 1 in 3,300 to 1 in 7,000 to 900 live births. It is important to note that the prevalence figures may vary based on different populations and regions. While the SMA type 3 is considered less severe compared to type 1 and type 2, early diagnosis and medical management are still crucial in providing optimal care for individuals with the form of SMA. Regular monitoring, physical therapy, and interventions to address mobility challenges can significantly improve the quality of life and functional abilities of those living with the SMA type 3. SMA type 4 is the mildest form of SMA, with symptoms appearing in adulthood. It accounts for less than 5% of cases. People with SMA type 4 experience mild muscle weakness, but can usually walk and perform daily tasks without assistive devices. Onset age varies, and motor milestones are achieved normally. Lifespan is normal. Patients with SMA type 4 generally have 4 to 8 copies of SMN2 gene. Prevalence less than 1 in 20,000 live births. Early diagnosis and proactive care are essential to optimize the well-being of individuals with SMA type 4. Genetic inheritance. The inheritance pattern of SMA is autosomal recessive, which means that both parents must carry a mutated SMN1 gene in order for their child to develop the condition. Typically, parents who carry one copy of mutated SMN1 gene but do not have SMA themselves are considered as carriers. Carriers have one normal copy of the SMN1 gene and one mutated copy. Carriers of the SMN1 mutation typically do not show symptoms of SMA because the normal copy of the gene compensates for the mutated copy. When both parents are carriers, there is 25% of chance with each pregnancy that their child will inherit 2 copies of the mutated SMN1 gene and develop SMA. There are 3 possible combinations of gene inheritance are as follows. 25% of chance, the child inherits one normal copy of the SMN1 gene from each parent and does not develop SMA, the child is not also a carrier. 50% of chance, the child inherits one normal copy of the SMN1 gene from one parent and one mutated copy from other parent, making the child a carrier of SMA but not affected by the disorder. 25% of chance, the child inherits 2 copies of the mutated SMN1 gene, one from each parent. They will lack the necessary SMN protein that is essential for the survival of motor neurons. This leads to degeneration and loss of motor neurons, resulting in the child having SMA. While there is currently no cure for SMA, research efforts are focused on developing therapeutic strategies to increase the production of functional SMN protein from SMN2 or introduce exogenous SMN1 to compensate for the deficiency. Approaches like gene replacement therapy, small molecule modifiers, and gene editing technologies hold promise for improving motor neuron function and ameliorating SMA symptoms. There are several treatment options available that can improve motor function and quality of life for patients. In addition to gene therapy and an oligonucleotide ACO, and other drugs are also being developed that target different aspects of the disease, such as increasing muscle strength or improving respiratory function. Physical therapy and occupational therapy are also important components of SMA treatment. These therapies can help improve mobility, strength, and self-care, as well as prevent complications such as joint contractures or scoliosis. Respiratory therapy is also crucial for SMA patients, as respiratory failure is a common complication of the disease. Respiratory therapy may include the use of mechanical ventilation or cough assist devices to help clear the airways. In addition to medical treatment, SMA patients and their families may benefit from emotional and social support. SMA can be a challenging disease to manage, and it is important for patients and their families to have access to resources such as support groups and counseling.
Hello, my name is Elif. I make anatomy and medicine videos. If you like my videos, please subscribe my YouTube channel and follow me on my Instagram and Facebook pages.